Knock, knock. Hello, washing my hands. Can I have your initials, please?
LB,
And what's your date of birth?
January 23rd, 1987.
What can I call
Lee.
you? Okay, Lee. I'm Megan. I'm a family nurse practitioner student at United States University. I'm here to do a cardiac assessment on you. Do I have your consent to record this and upload it to YouTube as unlisted for my instructor and my classmates to view?
Yes.
Okay, wonderful. I'm going to do a quick room scan. Start over here. Fan. It's my mirror. That's what I'm setting my computer on. That's just my Snellen chart, my tape measure, and my pen light. All right. So the first thing that we would do for this cardiac exam in the real world, I'm going to verbalize it for purposes of the video, but we would take a blood pressure in each arm with the patient lying supine and then sitting upright. The next thing I'm going to do is I'm going to assess his right internal jugular vein. So the patient needs to be at between a 30 to a 45-degree angle. I need to be standing on his right side. And in tangential lighting, I'm going to, can you kind of rest your head back? All right, and then look that way, please. Tangential lighting, I'm going to look for the highest point of the pulsation of his right internal jugular vein. It is kind of going to be pulsating inward as opposed to the carotid artery, which is going to be pulsating outward. And at the highest point of the pulsation, I'm going to put a card horizontally. So his highest point is about right here. The lower the better. The higher means that they have higher jugular venous pressure. So put a card like this, and then starting at his sternal notch with your ruler, you measure upward in centimeters, and his is about 2. So that means that it's 2 centimeters. If you were to add 5 to that, that means that his jugular venous pressure is 7, and it should be 8 or below. So that's normal. The next thing that I'm going to do is palpate his carotid arteries. So I'm going to, in the lower third of his neck, I'm going to just palpate. I'm feeling the pulsations. I don't want there to be any thrills. I don't want them to be bounding. I don't want it to be thready. So his carotid artery is a +2. There's no thrills. And the rate is in the 70s. Ideally, I'd feel for about a minute. Regular rhythm. And then, so that's the right carotid. Now I'm going to palpate the left carotid. Lower third of the neck. Same findings. He does not have bounding. He doesn't have threadiness. It's +2 in intensity. No thrills. And regular rhythm. Rate in the 70s as well. And you don't want there to be too much variation or any variation between intensity and rate from one side to the other. The next thing that I will do is auscultate his carotid arteries. So I'm going to do this with the bell and with the diaphragm. So look that way, please. With the diaphragm first, and I'm just listening for rate, making sure the rhythm's normal. His rate's about 70 a minute. And then I'm gonna listen with the bell, and I'm listening for bruits or turbulent flow. And there is none. So that's his right carotid artery. Can you look towards me now? So the left carotid artery, I'm gonna start with the bell, listening for bruits. There are no bruits, there's no turbulent flow. And I'm gonna listen with the diaphragm. His rate and rhythm are the same findings on the left as what is on the right. All right, and so next I am going to inspect his chest and thorax. In a clinic, I would have him shirtless, but for purposes of this video, we're gonna keep a shirt on. And first thing that I would be assessing for is inspecting his chest and his sternum, make sure the sternum's midline. I want to see if it's pointed inward or outward, pectus excavatum, or pectus capernatum. And then I'm also checking to see if there are any precordial pulsations. I want to see his chest rise and fall, make sure it's equal and symmetric. I'm looking at his abdominal aorta to see if I see any precordial pulsations. I shouldn't see it bounding out of his abdomen. I'm looking at his apical area, the point of maximal impulse, which is left chest, fifth intercostal space, midclavicular line. And I don't, you can put your arms down, please. I don't see it bounding. Sometimes you can see it pulsating, and that's not abnormal. If you want to see it pulsating and you can't with the patient lying like this, then you could have him lay on his left side and you might be able to see it then. But that's something that I'm looking for. Then after that, I am going to palpate the 5 points that I would usually auscultate on his chest. So the first part that I'll palpate is his second intercostal space, right sternal border, and it's his aortic area. And I'm palpating for heaves, lifts, thrills. I don't feel any of that. I can feel his heart rate, and it's regular. And then I'm going to palpate the pulmonic area, which is the second intercostal space on the left sternal border. And I'm feeling for the same thing, heaves, lifts, thrills, and I don't feel any of that. Then I'm going to palpate the Erb's point, which is the third intercostal space, left sternal border. Palpating for the same thing. I can feel a heartbeat, but there's no heaves, lifts, or thrills. It's regular, not bounding. Then I'm going to palpate the fourth intercostal space, left sternal border for tricuspid area, finding the same findings, no heaves, lifts, or thrills. And then I'm going to palpate the midclavicular line, fifth intercostal space on the left side for the apical area or the point of maximal impulse. I should not feel any bounding. I should feel a pulse. There's no thrills though, no heaves, no lifts. And if I were to feel the diameter of where I feel the pulse, it should be no bigger than, no wider than 2.5 centimeters in diameter. If it was, we might be concerned for ventricular hypertrophy, and we would look further into that. The next thing that I will do is feel for his abdominal aorta. First, I'm going to just feel with one hand. It's going to be epigastric, center above the umbilicus, and I can feel a pulse, but it's not bounding, it's not thready, there are no heaves, frills, lifts, and after that I'm gonna feel with both my hands on either side of it, and I just want to see if I can feel the diameter of it, which I can, and it should be less than 3 centimeters. And his is 2 centimeters. So that's a normal finding. And then I'm going to auscultate. So I'm going to auscultate the 5 auscultatory points that I just previously palpated. Auscultate with the bell and the diaphragm. So the second intercostal space, right sternal border for the aortic area, diaphragm and bell. Listening for the rate, listening for murmurs, clicks, rubs. I want to hear S1 and S2, which I do hear. I don't want to hear S3 or S4 or gallops. Then I will auscultate the second intercostal space, the left sternal border. That's going to be the pulmonic area. Diaphragm and bell. Still not hearing any gallops, murmurs, rubs. I hear S1 and S2. I'm going to listen to Erb's point, which is the third intercostal space, left sternal border, with the bell, with the diaphragm. Still no rubs, no murmurs, no gallops. S1 and S2 are heard. I'm going to listen to the tricuspid area, which is the fourth intercostal space, left sternal border, with the bell, with the diaphragm. No murmurs, no gallops, no rubs. S1 and S2, no S3, no S4. And then the point of maximal impulse down here at the apex and the fifth intercostal space, midclavicular line on the left, with the diaphragm, with the bell. Heart rate is normal in all points. It's 70, just like it has been in his carotid areas, and also in his abdominal aorta. But I don't hear any gallops. I hear S1, S2. I don't hear any rubs, don't hear any murmurs, clicks, anything like that. Now I'm going to auscultate his abdominal aorta with the bell and with the diaphragm. With the diaphragm, with the bell, listening for bruits or turbulence with the bell. There shouldn't be any turbulence or bruits, and there's not. That would be a sign of maybe some obstruction. And then I'm going to listen to at between the second or either the second or the third intercostal space on the left sternal border is where you can hear a physiologic splitting of S2. So I'm going to listen to that right now with the diaphragm. And you listen when the patient takes a deep breath. So take a deep breath, please. Okay. And on inspiration, you can hear a faint splitting of S2, and what it is the slight difference. You can hear it the best right there, but it's the slight difference of time between the aortic and the pulmonic valves closing. So you should be able to hear it on inspiration. You should not be able to hear it on expiration. If you can, it might be pathologic. So I heard it on inspiration for him. While I have my stethoscope out, I'm just going to auscultate his femoral arteries real quick. I'm going to do it over his shorts for the purposes of the video, but like I said, he'd be in a gown in clinic. So I'm going to auscultate his right femoral artery with both the diaphragm and the bell, listening for bruits. His left femoral artery, diaphragm, and the bell. Listening for bruits, also listening just to make sure that his heart rate matches all the other spots that I've been listening to and the rhythm is regular still. The next thing that I will do is I'm going to inspect his all 4 extremities. I'm gonna inspect for color. I want to see if I see any weeping or moisture. I want to see if his skin is pink or is it red? Is it pale? Is it taut? Is there edema? Are there shunts? Are there varicosities? Is there cyanosis? On his fingers, I want to look for splinter hemorrhages in his fingernails. That could mean pericarditis. I want to look for clubbing, which would be a sign of COPD, and I want to look for tar stains, which would be a sign of him being a smoker. So I'm observing all that. Everything looks normal, pink, warm, and dry. I don't see any splinter hemorrhages, tar stains, don't see any clubbing. Same with his legs. I don't see any edema anywhere, no shunts, no varicosities, no edema. The next thing I will do is feel, I'll just palpate. So I'm going to feel both arms, make sure I don't feel any pitting, make sure I don't feel any bounding or pulsations, and there's no pitting anywhere. I'll palpate his legs. I don't feel any pitting, no edema, no abnormal bounding pulsations. I'm going to do capillary refill in all 10 of his fingers, all 10 of his toes. So just pinch each one. It's less than 3 seconds. And each one of these, let me do all of the toes. Capillary refill is less than 3 seconds in all his fingers, all his toes. Next thing I will do is feel his pulses. So can you extend your arms, please? I'm going to feel both. Now with the carotid arteries, you don't want to palpate them both at the same time because the patient, it could affect blood flow to the brain. With the arms and the legs, it's not the same. You can feel them both at the same time. So palpating his brachial arteries right now, and they're even, regular rhythm, same heart rate. They're not bounding, they're not thready. I would call them +2 in intensity, no thrills. And then I'm gonna palpate his radial arteries on both sides. So the right and left brachial arteries, normal, no thrills, no abnormalities. The right radial artery and the left radial artery, no thrills, it's not bounding, not thready, +2 in intensity, regular rhythm, rate is in the 70s. And then I'm going to feel his femoral arteries. So right femoral artery and left femoral artery are regular, rate in the 70s. I don't feel thrills, no heaves, no lifts, nothing abnormal, steady +2 pulse. Then I'm going to feel his posterior tibial artery. And so you kind of have to feel deep in between the back of the knee and the fossa, medial and lateral, and you can feel a pulse here. Can't really feel them both at the same time because feeling one sometimes takes both hands. So I feel +2 intensity, regular rhythm, rate, same 70s. And then this one, +2 intensity, regular rate rhythm, no thrills. Same with the right side, no thrills. Left side, no thrills, rate in the 70s. Then I'm going to feel the posterior tibial pulse in the right side. And it is +2. It's not bounding, not thready. Regular rhythm, rate in the 70s. And then I'm going to feel, that was the right posterior tibial. Now I'm going to feel the left posterior tibial. Same findings, no thrills, not bounding. Intensity is +2. Rate in the 70s, rhythm regular. Then the left dorsalis pedis and the right dorsalis pedis. The left is +2, regular rhythm, rate in the 70s. Right dorsalis pedis, and no bounding over here. No thrills. And then the right dorsalis pedis, no thrills, not bounding, not thready, +2 in intensity, regular rhythm, rate. And that is going to be it and conclude my assessment.